So I think we can begin then. I'm Tom Freedom. I'm a sleep doctor from the northern suburbs of Chicago, and I've been a medical director of sleep programs, and I'm mainly clinical and teaching. I've done a little bit of research as well, but I'm going to try to help you to find a sleep doctor, give you the tools that are needed to evaluate and also to find one. And we're already starting off on the wrong foot here. Actually, today's the 26th, so I apologize for that. Anyway, so what we'll do is we'll look at some of the qualifications. How do you become a sleep doctor? These are things to look for. How do you find a physician? And this can generalize. Just a few things need to change. If you need another kind of a doctor, you can use these tools with a little bit of difference. How to assess the doctor, the type of things that you can expect during your visit, and how you should prepare to optimize the visit. And then, I don't know why I have what to expect from your physician, and then finally, what can go wrong and what you need to look for red flags. So, first of all, to become a doctor, you have to have some kind of an undergraduate degree. There are still probably some 6-year programs, but mainly 4 years of a university, 4 years of medical school. And then you do a residency. And in order to become a sleep doctor, you have to have a primary residency in one of these areas. Now, that may be changing. Sleep may become actually a primary specialty. The boards are working on doing that. But at least up to this point, you have to have some sort of an underlying specialty first. I happen to be a neurologist by trade. And then you have to be licensed by a state board. Some of the states also require you to have a prescribing license in addition to the ones that we all have to have from the FDA in order to prescribe medications. And then we do a fellowship, 1 or 2 years, typically 1 year for clinical, 2 years if you're going to do a little bit of research in sleep medicine. A good sleep program will be multifactorial. All of those previous specialties that I talked about. By the way, there's a handout in the app, so PDF, because I'm going to go fast through some of these. Don't panic when you see the websites, because there's a reference page that has all of the websites that are going to be on here that you can use. Yes, sir.
What fellowship is?
Pardon me?
What fellowship is?
Well, a fellowship is a training program. It's a postgraduate training program above and beyond the normal residency. So in order to have a specialty, you have to do something that's called a residency after you finish medical school. You train in the hospital. You are a physician. You're a licensed physician after 1 or 2 years, but you're still under the supervision of other physicians. During a fellowship, you have a little more leeway, but you're still being trained by people who are already certified in sleep medicine. So it's somewhat like a residency, but more responsibility than one would have. A lot of times, the fellows are running the clinics in the universities, and the physician will just come in for 5 or 10 minutes and see you, the attending physician. It's really the fellows that run things. The fellows read the sleep studies. So it's a training program with much more responsibility to allow us to push those doctors out of the nest, and they'll be off on their own. And then you have to be certified. At least up to now, you have to be certified in your primary specialty in order to be certified in sleep medicine. And there are a number of qualifications and things that you have to do, but mainly there's an exam that one needs to take, and one needs to recertify every 10 years to maintain that specialty, in addition to education and a whole number of other types of things to make sure that we continued not only knew what we were doing, but we know what we're doing presently with the new information and knowledge that goes on. You want to make sure that your physician at least belongs to the Academy of Sleep Medicine, and if you're looking for somebody who treats narcolepsy, it'd be nice if they're members of the Narcolepsy Network as well, or some narcolepsy association, just so that they have that specialty. A lot of sleep medicine doctors, not all of them really focus or at least have that expertise in narcolepsy. So you want to make sure that they have that. The other thing is for sodium oxybate, Xyrem, I don't know if you know that medication or not, but you have to have another qualification, and you have to take it's a relatively short exam, but you have to take an exam and do a test every 2 years. The FDA requires that for certain medications, this risk evaluation and mitigation strategies, when they think that the medication may have a little more risk than the average medication. So you need to make sure that your physician, narcolepsy doctor, can prescribe Xyrem if they need to. And then again, you can find a sleep physician using a number of these different links, and I'll go through that a little bit later on. Local support groups, word of mouth. Place like this, you meet someone that's in your town, you're not happy with your doctor, who are you seeing? Are you happy with that doctor? Very often, I get a lot of referrals from patients that I see and that are happy with my care, and that probably is almost as good as, in fact, probably better. If you know someone and trust them and you're getting their okay on this physician. But the local support groups are very, very good as well. So this is how you would use the narcolepsy link. You'd go in there, you find the doctor. This is also, I don't really treat pediatric patients. The person up there who's in our practice does, as a matter of fact. And then you narrow down, you can look at that person, you can get their information, you can get a number of other things. Make a list of these doctors that you come up with, and then some of the tools that I'll show you later on will help you to narrow it down, and also to you don't want Dr. Howard, Dr. Fine, Dr. Howard. And the other thing you don't want, it would be so nice if it was easy. You walked in the door and you could immediately tell this is not the doctor for me. But unfortunately, it just doesn't work out that way. So it may take a few visits before you realize, guess what, I need to look elsewhere. Like anything else, spend time. You have to spend time. You have a marriage partner or a significant other. You spend a lot of time making sure it's the right person, and you want to do the same thing when you're looking for a physician. So there are a number of red flags, and you can find this information. I'll tell you where to find it. Again, in state medical boards, all of that stuff will be in your handout. But you want to make sure, have they been sued? Do they have any outstanding legal issues from the state medical board? And all that information is available to the public. When you make an appointment, do you talk to a human being, or do you get a voicemail? And sometimes, you may get a voicemail that says, leave your number and I'll call you back. You get busy, our program gets busy, but our folks will call you back. You don't want to keep going through one voicemail, another. You're going to start worrying about that. When you come in for your first visit, can you sit down in the waiting room, or are people just waiting for hours? There's a doctor behind. Does the doctor not listen to you? They want to start treating you before you even have told them your entire story. And again, if you question, or you say, are there any other options? If the physician gets impatient, you got a red flag there. And also, direct communication. At least, I don't do a lot of phone calls myself, but we have an email system. And if I do an MRI on someone and they have a brain tumor, of course I'm going to call them. But if somebody has a question about medications, oftentimes it's just a little more efficient to do that through email. So there's really nothing wrong with that, but you need to be able to directly connect one way or another with the physician. If you can't, then there's a problem. You want to find out, see how easy it is to make an appointment. Make sure that you have directions as far as what to bring, what you need to bring with you. We ask people to bring either, you're probably better off bringing your old records, but at least have them sent. And then also call to see if they got the records. It's nothing like coming into a place and having to start from scratch. They should have good information about insurance. They should be able to tell you your co-pays, that sort of things. And then also directions on how to get there, where to park, how to get to the building. So again, if you come in, particularly if you have a late night appointment, if you don't feel safe, for example, if you don't know how to get to the office, if it's hard to check in once you get to the office, if you're waiting forever to see the physician, at least without explanation. We all get behind, okay? Someone comes out, Dr. Smith is going to be 30 minutes late, sorry. That's one thing, but if you're there for 40 minutes and have no idea what's going on, you need to reconsider who you're seeing. Are you dealing with a human being? Did somebody come in and say, hello, how are you, greet you by your name, introduce themselves? Do they wash their hands before and after they see you? Are they dismissive? If you come in with an article, people come in and tell me crazy things, and I just have to kind of, I'll look into it, but I don't think that, I'm not going to ridicule someone, but you'd be surprised how often that happens. You may have experienced that yourself. If it's something I don't know, I get a lot of information from patients. You know, we were involved with a program that I didn't even know was involved for a new drug. It was one of my patients that brought it to my attention. So sometimes you folks through the network hear things before I do. I hear them through the journal. You know, you hear them directly before they get published. So certainly, if your doctor's not willing to listen to you or look up the article, then guess what? Time to find someone else. Does a doctor explain why you're getting the test, what the tests are? Do they explain how you're going to get the results back to you? These are things that you should also. And are you contacted, even if the results are normal? Now, we also have an electronic medical record, and we may with sleep studies we don't. With blood tests, we may send you a message your blood tests were normal, and then you can get a hold of them. With sleep studies, we pretty much call everyone with the results. But you should be contacted, and if you need further explanations, you should be able to talk to someone. If you don't talk directly to the doctor, at least we have nurse specialists in our program, and they're very, very, they understand sleep studies, they understand sleep disorders, and they spend a long time explaining. That's all they do mainly is talk to patients. But you got to get your results back. You got to know if they're normal or not. So how are you going to assess the physician? There are a lot of different ways. Consumer guides, both for healthcare and sometimes even general consumer guides. Yelp, has, as much as you trust Yelp. Certainly the state medical associations, the state medical boards, certifying bodies. You can sometimes look at the various boards and see if they're certified or not. The American Board of Medical Subspecialties, for example, and I'll show you that in a little bit. And then there are a whole bunch of other sources you could look at as well, that are again consumer or healthcare sources. Don't panic. There's a handout that's called references that has all of these on it as well as the websites. But these are just some of the different sources that have evaluations of physicians. I can't necessarily vouch for all of them, but we're on most of those. And again, these are also going to be on your handout. The boards, the state medical boards, the Board of Medical Subspecialties that I mentioned, and the American Board of Sleep Medicine. There is both an older Board of Sleep Medicine that no longer certifies doctors. What happened was sleep medicine was an independent board that was outside of this main board here. And about 12 years ago, the American Board of Sleep Medicine became part of that board. But those of us who got into this before that may have this board certification. Some of us have both, which is even better. But at least if you don't find them there, look here and see if they're in there. The younger doctors in sleep medicine should all be here. Some of the older ones may just be here, and it's a bonus if they're members of both. For the old board, once you've taken the exam, you're a sleep doctor for the rest of your life. For this particular one, you got to recertify every 10 years. So that may be a little more rigorous. So you may want to look for something like that, but you're going to get someone that's been doing this for 30 years, expert. You don't want to reject them because they don't have that newer board necessarily. And then again, Health Grades is one of those consumer health type websites that will help you. Now again, this is all what other people talk and what people say, so can be sour grapes sometimes. You may get a bad review, but if you've got 40 people giving someone a bad review as opposed to 38 giving good ones and 2 giving bad ones, you can judge at least partly by that. And again, it's only just a little piece of information. There I am. Anyway, before I go any further, any questions so far? I went quickly through it, but again, you can review the handout. Yeah. If you go to the app and you go into the schedule, you should see 2 PDFs underneath the schedule for this. You're welcome. Yes.
When you were talking about finding a doctor, so for kids that are like 16, they have a pediatrician already, but they're trying to find a sleep doctor, and I know they're technically a pediatric patient, but they're also, 16, 17. So
It's variable. In our system, you know, I see kids as young as 16. And underneath, less than 16, you may want to look for a pediatric sleep specialist. And again, that was checked under that one thing. Although I don't see kids, it was checked. You know, we see pediatrics. So you can, in fact, when you go into that apnea link, you can check, you know, see pediatric, include pediatrics, or only pediatrics, and you can narrow it down to that if they're under 15. If they're 16 or older, they probably should be seeing an adult sleep specialist. All right. So, when one comes into the office, we do an evaluation. We usually start with questionnaires. Nowadays, people can fill most of those in prior to the visit online. And we also have these little tablets when they get there if they haven't done it online. And for those who like paper and pen, we still have those as well. It's going to be like any other doctor visit structurally. We're going to take a history, but we're going to focus on the sleep history. We're going to do an examination, but again, we're going to focus on certain things perhaps that may be more apt for someone that we think has a sleep disorder. If someone comes in and they're sleepy, I'm going to look at their tonsils. I'm going to see if they perhaps have a risk for sleep apnea, for example, just to try to evaluate all the possibilities of what's making them sleepy. So there's some things that we do that may be a little bit different, but generally it's going to be like any other doctor visit. Again, the comprehensive sleep history, other sleep problems. If you come in sleepy, we're going to ask a number of other things about your sleep as well. And then just general medical conditions, operations, hospitalizations. It's like another doctor's visit, really. Medications that you're taking now and those that you've taken in the past, and any bad effects you've had from them, allergies, social history. So this again is pretty much what you're going to do as if you're, you know, at another doctor's visit. And then this review of systems, a shopping list of things that we just kind of, you know, go down. Do you having any symptoms from the top of the head to the feet? And cataplexy is quite interesting because sometimes you don't get that in the first visit because it's so subtle. So someone may just kind of, you know, drop their head or something like that. And maybe, and there are times that it'll take 2 or 3 visits, 4 visits before you actually can tell someone's having cataplexy, and they may not even realize it. So there's certain subtleties, things that we ask, and we ask over and over again, and eventually you may find out that someone actually has type 1 rather than type 2 narcolepsy. You all know what I mean by that, correct? Yeah, okay. And then again, a general exam, vital signs, neurological exam, and if there are any other specialized type of things we need to do as a sleep exam, we'll do that. And then we'll talk about what we found, we'll talk about what we think is going on, and then any testing if it's needed. And then I try to give people at least a little bit of a map of what will happen after the sleep studies, what sort of things are out there that we can do. And specifically narcolepsy, I may talk about some of the medications that are out there, sleep hygiene and getting enough sleep and taking naps, and then the follow-up. Sometimes we'll do that over the phone after the sleep studies. Sometimes I'll give people a little bit of an idea what's going on. Sometimes I'll have people come back before before we come up with a specific plan. It really depends. Most of you are familiar with this, so I'll pretty much go through all of this. Sometimes blood tests, sometimes urine testing. I think I've done one spinal tap for narcolepsy in my entire career. And if you were there this morning, you know, some of the assays for orexin may not be what we think they are. So it's something I hardly ever do. I don't even do the HLA testing anymore.
What drove you in that single patient to do it? What made them so
well, she had a number of other things. She has connective tissue disease. She's got migraine with aura. At one time, we thought she was having symptoms. A very complicated patient. And I'm cheating a little bit because they were doing a spinal tap for other things, and so we just got the fluid and sent it on top of that. But actually just primarily doing an LP, a lumbar puncture, for narcolepsy. I don't think I've ever done one. I mean, Mayo now has a commercial test. They've had it for probably, I don't know what, 3-4 months, 6 months, I don't know exactly how long. And I haven't sent one yet. But if there's a question, I mean, you're not so much concerned necessarily between whether someone has narcolepsy type 1 or type 2. You're pretty much going to treat it the same way, but you would like to distinguish between idiopathic hypersomnia and narcolepsy type 2. And I've been doing this a long time, and there are patients that I'm not sure. So they'll have one positive nap, and they'll have sleep paralysis, but they don't benefit from naps, or they take long naps, or they wake up in the morning and they're still tired, but yet, well, I laugh and I, feel a little funny feeling in my face. So it gets very difficult. And so it's important to distinguish between idiopathic hypersomnia and narcolepsy, and sometimes that becomes difficult. So that might be another reason to do spinal tap. Probably not a bad idea to have somebody come with you. In fact, a bed partner might even be more helpful. Any sort of behavior, REM behavior type of. I don't like using the term REM behavior disorder. I'll call it dream enactment, because I think REM sleep behavior disorder is something that leads to Parkinson's disease. I think that as we saw this morning, nice and positive, you're not at risk for getting Parkinson's disease, even if you have dream enactment. No more risk than anyone who doesn't have narcolepsy. But dream enactment, it's nice to have somebody that can tell you these things, and the sleep is often disrupted. You saw number 5 as one of the characteristics of narcolepsy, as being disrupted sleep. I think that's the one a lot of people miss. I'm not sure if you're aware of the study a number of years ago. I think only 24% of sleep doctors could identify all 5. And I read the study, but I've forgotten. But I bet that the disrupted sleep is probably the one that most of them don't identify. Better to carry your records with you, or if you have a little drive, if you mail them, as I said, make sure that they got there. And a lot of times it happens that they just don't. You want to know how long the appointment's going to be, and then you've got to have a goal. What do you want out of this appointment? We're here working for you, and we need to make sure that we're doing the type of things that you want. Maybe you don't want to take a medication at all. What can I do without taking a drug? Maybe you want to change medication. Maybe you want to get into a clinical trial. I mean, there are a number of different goals that people have, and really have an idea of what you are looking for. Again, a number of questions. I'm not going to go through every one of these, but they are on your handout, the type of questions to ask the physician when you come in. And that certainly is not all-inclusive, but certainly have an idea. Write them down. And again, with our EMR, people forget their questions. They'll just send me an email, oh, by the way, and I'm happy to answer the questions. But those are important. If we're doing doctor speak, just stop us and say, what does that mean? We just sometimes get carried away here and use terminology that perhaps the average person doesn't understand. So, again, I think the way to get that across to the physician is, I want to be able to explain this to my family. Can you use terminology that they would understand? And then, you want to look at expectations. How long will it take for you to get your results back? 1 to 2 weeks to get the sleep study results back, or maybe 72 hours, depending on how fast we are. And then, okay, here's the plan. What if that doesn't work? Do you have other options? Do you have Plan B? Do you have Plan C? Do you have Plan D? You need really to get someone that's multidimensional, that's thinking about what to do if this doesn't work. And are there any activities that I'm going to have to avoid, not do, if I am being treated for this? If you start a medication, there's certain things you may have to avoid. People will call me that started on pitolisant, what's Wakix now, and I've got a cold, can I take an antihistamine? Well, you can, but there are only certain ones that you want to take that aren't going to interfere, for example. So these are the kind of things that your physician should know about. And again, you want to know how long is this going to take for me to get better. Maybe it'll be immediate, maybe it's going to take 3 weeks, maybe we have to do adjustments. What happens if there's side effects? So there are, again, really a number of questions that you need to ask and that your physician should be able to provide. So, am I typical? Am I not typical? What do I expect? What does the average person with narcolepsy expect? Are there, what happens to other patients? So again, these are the kind of things that you want to ask. You want to keep track of that. You may want to write all of this down. People sometimes will write questions down. Usually we print out a whole list of things. What I'm going to do, I'll kind of type out a little bit of a plan for people. And I have these macros with different handouts that explain narcolepsy as well. But other physicians may not do that. So you want to gather all the information that you think the physician is going to need. Some of that should come from the office when you make the appointment. You want to have a clear idea of what symptoms you are, so you can pretty much explain to the physician what you're having. Anything, no matter how silly you think it is. You may want to do a little bit of research, look at reliable sites, look at universities, look at Narcolepsy Network, but look it up and see if you can get a little information yourself. And then there's some tests, if you haven't done these already, that you can do. You can do the Epworth Sleepiness Scale, the Swiss Narcolepsy Scale. These are all available. You may be familiar with Epworth, probably most of you are, but it determines how sleepy people are by asking a number of questions of how likely you would be to fall asleep in various situations. And this is the Swiss Narcolepsy Scale. It asks about sleepiness and cataplexy mainly, and it also kind of teases out insomnia, teases out other causes of sleepiness by answering questions. So any idea who these people are? These are revered figures. I think only 2 of them are alive. William Demint, you've probably heard that name, and Alan Rechtschaffen, who came up with the way that we score sleep studies. Dr. Jovet died a couple of years ago. He did a lot of the animal experiments looking at the brain stem. And a lot of what we understand about paralysis during REM sleep, for example, came from Dr. Jovet. Dr. Kleitman lived to be 102 years old. At one time, he was probably the expert. He was a scientist, probably the world's expert on sleep. He wrote a textbook, a couple of editions of that textbook, and all of these 2 folks were trained in his lab. Dr. Azarinsky was the one who was watching the babies as they sleep and saw their eyes kind of darting around and rigged up this little EEG and things to put around their eyes and realized, and the discovery of REM sleep came out of that lab in 1953 was when they published. Anyway, a little bit of history. So you want your doctor to be a professional. Doctor should know what's going on. The doctor should be skilled, and most of what we do is an exam. We don't do a lot of procedures, but certainly should have those skills and should conduct themselves like a human being. We're all different. Some of us are extroverted, some of us are quiet, but you should certainly be treated with respect, and that doctor should have good judgment. If they recommend something that's just crazy, for example, if they don't look at your drug and they give you another drug that's going to interact with it, for example, and it happens a lot more than we would like. But ultimately, you should feel respected. You should feel cared for by your physician. Communication, you should leave that office at least with some understanding of what's going on. And advocacy, particularly for young people with narcolepsy, but even people at the workplace. Somebody's going away to school, for example. We write letters, we explain to student health about the person's disorder. People, for example, who are taking Xyrem and then go away to school, it's a big problem. What do you do with it? I mean, it's very easily diverted by other kids that perhaps may want to use it as a recreational drug. It has to be locked up. There really have to be a lot of safeguards, and you have to make these plans. When we're seeing folks that are, juniors in high school, we're already sort of thinking about how we're going to do this, working with them, working with the parents to make sure that that goes smoothly. And then figuring out how to get them in to see you when they come back, to visit from school, making sure that they have appointments. But then also just in general, you should be able to have timely appointments back with your physician. So again, availability, affability, and ability. There was an old neurologist, and it was the 3 A's, and you certainly, ability is important, but you see it's number 3. You have to be there, you have to be a pleasant person, and you have to know what you're doing. One way or another, you got to be able to communicate with the physician. The staff should also be well trained. I'm not going to go through the whole staff, but what happens if things don't work? What are you going to do? So sometimes the doctor can be the best doctor in the world, and it's chemistry. Some people just don't get along. There may be not a problem with that physician. Again, the physician makes you wait without giving you any explanation and then rushes through the appointment. You don't want that to happen. You don't know what's going on. You ask questions and it's just, oh yeah, and just quick explanation. Or the doctor doesn't listen. Again, you'd be surprised the kind of stories that I hear from people. Again, the office staff is important. You just don't feel comfortable, you don't feel safe. Your doctor doesn't talk to your primary doctor and the other doctors that are treating you. At least send them letters. And if it's something that you need to do by phone, you can't get a hold of your doctor. Or if your doctor's away, there's no coverage. And again, rude condescending, there's a lot of that, and it's unfortunate. I'm just going to go quickly through this because it'll all be on your handout, but these are the different places you can look at. And again, you can look at your state boards. So I'm just going to look at Illinois, and the first thing you can look at is make sure that there are no, you can go at least in Illinois, you can put in the name and see if there are any disciplinary actions, and fortunately there are none here. But it'll tell you there's an active license here. This is when I was a resident, so my license expired as a resident, and then I got one as a physician. It'll tell you when they should be getting their next. So there's a lot of information in the state boards. And then the board, the American Board of Medical Subspecialties. You can tell if your doctor is certified in sleep medicine, and you just go through. I'm sorry, my mistake. That's the old board. So you can actually go into the old boards and see again that the physician is certified by the old sleep medicine boards. If they're an older doctor, they may not be certified by this board. Again, nothing bad against that. They can be the greatest sleep doctor in the world and just never got around to taking these boards. You could grandfather into this the first 5 years the board came out. Once that happened, you have to do a fellowship. So some folks just didn't meet the deadline, and so don't hold it against somebody if they're not part of that. But that's sort of the official board. Internal medicine, surgery, all of the major medical specialties are part of that. But again, you can go and put in a name, make sure that the physician is certified, and again, you can look at what certifications they have. And so it may take time, it may take a lot of effort. It's definitely worth the effort, because this is somebody that you hope you're going to have a long-term relationship, that they're going to take care of you, they're going to care about you, that they know what they're doing. And we all make boo-boos, okay? So also own up to their mistakes and try to make good on whatever they did. Should be professional, respectful, available, and should be able to communicate with you. And that's the reference, the other handout that's called reference or reference 1. And I think that's all I have. So do you have any questions? I'm happy to answer. Thank you. Yes.
Information on the broad subject of narcolepsy.
Yes, sir.
My wife was a narcolepsy patient for 60 years.
Mm-hmm.
And does any national organization put anything out there that it would be a broad, general set of information to get a patient's organized into the appropriate care profile, both personal as well as physician.
Well, you know, certainly the network is a place to start. I'm assuming you've been on their website and you and navigated the narcolepsy web network.
To a limited degree.
Yeah, that's probably the major source. Some of the university websites have also in their sleep programs. For example, Stanford would be a place to look. I think Mayo would be a place to look. Cleveland Clinic. I mean, those three would have a lot of information. As far as any specific books on narcolepsy, I'm not sure that there's any offhand that I can recommend. But I think those are the places to start. And again, we give handouts to people who come in about narcolepsy and the various things that you can do.
I don't know if this is what you're kind of asking, or it might be a totally separate question.
Mm-hmm.
But I know that one of the struggles I have found is when I take my son to a doctor, so let's say we go to a dermatologist. When he has narcolepsy in his own arm, what's that? I've heard of that, I don't know. They don't know. So part of the struggle we're having is every doctor we go to, I'm having to teach them what narcolepsy is, which I'm fine doing, but it's not getting him the quality of care.
Yeah.
Because I've, like when you were saying, I was thinking this is kind of probably the right time to ask it, but I feel like there needs to be some sort of a resource or something that, as I'm making appointments with doctors, that I can give the doctor and give them, like, here's a little one-page thing about narcolepsy.
Yeah, yeah.
Here's where to find, because I'm finding that they're prescribing medicine that's not going to work with Xyrem, and it's on me to go do that research and do that.
Yeah, again, we give we put together a one-page handout. It's not on our website, but if you want to email me, I've got again on that reference page, that very last one. There's my email up there. If you want to send me an email, I'll send you a copy of the patient handout.
Yeah, the other thing is we're about to completely retool our website, so any suggestions you have for things will be helpful. Send it to somebody on the board, and we'll make sure that that gets included in consideration. There
Yeah.
is a lot on it now.
Yeah.
You have to bang around on it because it's not as intuitive as we want.
Unfortunately, physicians are not educated about sleep in medical school. I was quite fortunate in my medical school. I went to U of I, and I can brag I had twice the amount of training in sleep medicine that most sleep doctors or most physicians get. Twice as much. That means I had 2 lectures instead of 1. You know?
Really?
Seriously.
No,
Very, very little. And I think what's happening now that sleep medicine, particularly I think after they became part of the medical subspecialties, and it's actually administered by internal medicine, I think a lot of the primary care doctors are beginning to understand more and more about sleep. But you know, sleep apnea and insomnia, I mean, those are the biggies. And you know, the emergency, someone goes to the emergency who has narcolepsy, it's almost hopeless. And you know, I tell the patients, have them call me. And if I'm not around, one of my colleagues, because they have no idea, especially for Xyrem. But yeah, send me an email and I'll send you that page. In fact, all of you, I'll just send you the page that we hand out to patients. Other questions? Yes?
I was diagnosed in 2007 with narcolepsy.
Mm-hmm.
I've been on my job for 21 years, and I've been a supervisor for about 15 and a manager for 4. And I rarely take off work. I've had cancer, had kids and everything. But recently I've become kind of stressed on some issues. And when I mentioned it to my doctor that I needed FMLA and also some work accommodation, he was like, well, I don't know if I can give you that.
There's a sleep doctor?
It's actually a school doctor.
Time to find a new doctor. I'm sorry. I'm sorry, yeah.
I felt that, and I was like, does he not realize what I'm saying?
Yeah,
You know, I haven't been on FMLA but twice, and
yeah,
that's when I had my children.
yeah.
But I had high blood pressure and some other issues.
No, that's, again, one of the things I talked about is advocacy. And if your doctor's not advocating for you, then you need to, yes, absolutely. Sir?
Where are you from?
I'm from the northern suburbs of Chicago, Glenview, Illinois. Glenview. We're a medical system, North Shore University Health System in Glenview, Illinois. Well, actually, it's located in Evanston, but I'm Glenview Hospital.
Do you have a lot of patients that travel a long distance?
I have a few. I have, what do you consider a long distance? I have some patients I used to be at Loyola, which is probably about 25 miles from where I am now, and I certainly have patients that travel from there. I've got a few patients that travel probably 40 miles, 50 miles from outlying areas. I've got people that come from,
Flying hours and hours away
yeah,
to go to a doctor, and I don't know how they do that.
yeah. So I've got people that come from Wisconsin to see me, so some distance. I don't think I have anyone that actually flies, and I've got one patient who comes from Valparaiso, Illinois, which is probably or Indiana, which is probably about 60, 70 miles away. So they do, because there aren't a lot of people out there who understand narcolepsy. It's unfortunate. Any other questions? All right, well, thanks for your attention.
Thank you.